So, hello everyone. My name is Yanran. I'm from Shanghai Jiao Tong University. So today I want to present about the topic of temporal lobe epilepsy. To start with, I want to present a case that I've seen during my AMI-QT rotation. So this is a 42-year-old female. She has a long-standing history of epilepsy, and she had a right temporal lobectomy in 2012. When she presented to us, she said October the 30th, 2024, she experienced a seizure. The semiology is similar to before. She described it as when she was walking on her way out of home, she suddenly felt a rising sensation from her stomach and a deja vu sensation, and then she fell over the ground. It is very interesting that she had a video camera in front of her house, which has recorded the whole episode. She lost her consciousness for hours and was discovered by her neighbor 3 hours later and was sent to the hospital. She then stayed in the hospital for 4 days, and comprehensive workup has been carried out. She reports some residual weakness, fatigue, and some soreness around her body. And when all this happened, she said that she was only taking Keppra 500 milligram QD. So about her seizure history, she first had her seizure at age 13. It was in 1995, and it was in 2012 that she underwent the right temporal lobectomy. Then she experienced a 8-year seizure-free time, and it was in 2020, March 2020, she had a breakthrough seizure episode. And 2 months later, she had another seizure episode in which she totally lost her consciousness, had some drooling and tongue biting. At that time, she went to our clinic and we started her on Keppra 500 milligram BID and lamotrigine 15 milligram BID. And 1 year after, she had another seizure episode. And then 3 years later, in April this year, she reported that she had an aura in which her described it as a abdominal pain and sensation. The episode lasts like 2 minutes, and she retained her awareness during this episode. So at this time, she is only taking Keppra 500 milligram once a day, and the blood test shows that the Keppra is therapeutic level. And at this time, she had another big seizure, and so we talked with her and decided to start her Keppra 500 milligram BID. So we have some objective tests done in 2021. She had an MRI brain which showed post-surgical changes of the right temporal lobe with associated encephalomalacia and gliosis. And also in 2022, she had a 72-hour EEG, which shows some slowing of the right hemisphere, and especially the right temporal area, and there are some sharp waves seen coming out of the right hemisphere. Another interesting part of her case that she does have some psychosis. We're not sure if this is related to her seizure or this is related kind of part of the post-temporal lobectomy complication. So she has some paranoia. She had an ideation that she is being monitored and she is being reported to the government. So she sometimes will come to the clinic wearing hat and glass because she believes that she is being monitored, and she may run out of the clinic without her prescription because she believes that she is being reported. And she has also been hospitalized on multiple occasions due to her psychosis. And also she has some cognitive impairment. She reports some memory problems. She cannot remember faces, names, and she constantly needs to make a list. So it's a very interesting case. And now I want to talk about the temporal lobe epilepsy. So, epilepsy is actually a very severe condition, debilitating, affecting millions of thousands of millions of people around the world. And what is focal epilepsy? So focal epilepsy, also known as localization-related or partial epilepsy, it arises as a consequence of a focal brain pathology or as a part of syndrome of genetic or unknown causes. And with all of the focal epilepsies, those coming from the temporal lobe is the most common. So we can see here it is a picture of the brain, and what is colored is our temporal lobe. So next, I want to talk about the different types of temporal lobe epilepsy. Actually, we have two types, the mesotemporal lobe epilepsy and the lateral temporal lobe epilepsy. To begin with, I want to talk about the mesotemporal lobe epilepsy, the MTLE. So basically, it involves the hippocampus, parahippocampus gyrus, and amygdala. It is the most common form of temporal lobe seizures, and it is usually secondary to a pathologic process called hippocampal sclerosis, and I will talk about this more detailedly later. Also, we have another type of temporal lobe epilepsy. This is called lateral temporal lobe epilepsy. It is also known as a neocortical temporal lobe epilepsy, and it is very rare. So most commonly, this is secondary to genetic or acquired structural or anatomical lesions. So we can see here, this is for the mesotemporal lobe epilepsy, right? This is the hippocampus, and this is the amygdala. Okay. So for the next one, I want to talk about the etiology of the temporal lobe epilepsy. So most commonly, this is usually due to the hippocampal sclerosis. And also it can be due to some infection, all kinds of central nervous system infection, including encephalitis. It can be due to the tumors, including hematoma or some glial tumors. And also it can due to some all kinds of traumatic brain injury, vascular anomalies, genetic reasons, and some cryptogenic reasons. So now we know that the hippocampal sclerosis is the most common pathology underlying all of these things. I want to dig this more. So we can see from the pathologic examination, what we have is the neuronal loss in the hippocampal structure. It is mainly from the CA1, CA4, and dentate fasciculus region, with usually sparing of the CA2 region. We can see from the sliced below, the picture below, that the CA1, CA4, CA3, the neurons are mainly lost, with the CA2, still we have many neurons staining here, right? And also accompanied with all these kind of neuron loss, we will have the astrocytic gliosis. So this is the pathologic findings that is most common with all the surgical treated temporal lobe epilepsy patients. And also very interesting is that the presence of the hippocampal sclerosis is kind of a prognostic factor in the outcome. And actually, it means a better outcome for patients who are surgically treated. So next, I want to talk about the radiographic feature of the hippocampal sclerosis. Typically, what we have is the reduced hippocampal volume and increased T2 signal and abnormal morphology, meaning the loss of internal architecture of the hippocampus. We can see from the coronal image, MRI, this is a T2 sequence, and we can see for the left side of the hippocampus, there is definitely the loss volume of the hippocampus, right? And there is a increased T2 signal compared to the right side. So this all means kinds of the neuronal atrophy and some gliosis going on. Okay, so next I want to talk about the seizure semiology. So what patients will present with, right? So most commonly for the patients with temporal lobe epilepsy, they will present with focal seizures with impairment of consciousness or awareness. This is previously known as complex partial seizure. And approximately like 1/3 of patients will also have the focal seizures evolving to bilateral convulsive seizures. And this is also referred as a secondary generalized seizure. and only a few people they will have the status epilepticus. So what are the distinctive features of patients about their seizures, right? So so to begin with, I want to talk about an aura. So what is aura here? So actually, this is a kind of focal seizure with retained awareness, and it is a focal seizure with sensory or psychic symptoms. Patients will usually describe it as a rising epigastric sensation. It's likening a rock roller, and some patients will have some psychic or experimental phenomenon such as deja vu, jamais vu, or fear sensation. And less commonly, patients may have some hallucinations, including some taste hallucinations or some olfactory hallucinations. It is worth to mention that this kind of aura or these focal seizure with the retained awareness, they can be isolated or they can proceed with the focal seizure with impairment of consciousness. So next, we will talk about the focal seizure with impairment of consciousness or awareness. So this is the most common type. And patients usually will present with a behavioral arrest and staring. The episode usually lasts like 30 to 120 seconds. Um, and very interesting that commonly like 60% of all the patients, they will have automatism. So this is a kind of stereotyped repetitive movement. So in our temporal lobe epilepsy, the symptoms are usually very mild and it may involve the hands. The patients may have the picking, fidgeting, fumbling with their hands. And also very typical is that they will have some mouth automatism. Very typical findings are chewing and lip smacking. Like, okay, so these are the automatism. And later about the post-ictal period, post-ictal confusion is kind of common, and some patients will have some post-ictal psychosis, which will last like days to weeks. But this will, interesting, will not start immediately after the seizure. And also patients may present with post-ictal hemiparesis, which is contralateral to their localization of their seizure. And the seizure of the dominant hemisphere can also present with the post-ictal aphasia. Then if the patients present to us, how can we evaluate them? So most importantly, it is the EEG. So what we can have is the sharp waves and following by some slow waves in the EEG, especially in the electrolytes around the temporal region. So we can see on this EEG on the left side that there are some sharp waves, and this is very distinct from the background. And also we can have some following slow waves. And also this is very specific, and like if we have some repetitive EEG studies or some prolonged ones, it can actually diagnose like 90% of the temporal lobe epilepsy. So another modality that is very important is our neuroimaging, right? So to begin with, usually we will have a MRI. MRI are extremely important in finding the hippocampus sclerosing. So like on these slides, as we mentioned earlier, there is also on the T2, there is hyper signal, and also we can have the hippocampus atrophy showing here. And what's to mention is that we always want to have a high resolution and thin sliced MRI study across the hippocampus region so that we can better identify the lesions, right? And also MRI is also important for finding out other etiologies, including like infection, stroke, and vascular anomalies. Also, we can use some functional or some metabolic images, including PET, SPECT, or functional MRI. So all these studies are extremely important for the pre-surgical evaluation to better localize the lesion. And then if we evaluate and diagnose the patients, how can we manage them? So to start with, we usually have the pharmacotherapies, and definitely the first line is the anti-epileptic drug, the AEDs. So the most effective AEDs are those used to treat focal epilepsies, such as the carbamazepine, oxcarbazepine, levetiracetam, lamotrigine, or topiramate. We usually use a monotherapy, or more oftenly, actually, we use a combination of medication to achieve adequate seizure free. But kind of not satisfying is that about 1/3 of patients, they do not have a fully resolution of seizure after initiation of the AEDs. And some patients, they may respond at first, but then they will have some remission of their seizure, and then they will generally become some drug-resistant epilepsy. And at this time, what we can have is only the surgical options. So for the non-pharmacological options, we'll have the surgical ones, or we can have some neurostimulation ones. For the surgical one, the most effective or safe choice is actually the open surgeries. We can have some standard anterior lobe, temporal lobe lobectomy as shown on the diagram on the left side. And also we may have some anterior medial temporal lobectomy or selective amygdalohippocampectomy showing the right side. It is more selective and only affect less regions. So actually, these surgeries has been proven to have a better long-term outcome compared to with chronic medication use. And also, as we know more about the epileptic networks, the doctors now are now considering some other techniques, including all kinds of minimally invasive techniques like the radio ablation, things like that. And also we can have neural stimulation, including the vagus nerve stimulation, but also often these are considered as the options for patients that are um, not applicable for the surgical ones. Finally, I want to talk about the clinical cause of the temporal lobe epilepsy. So usually they start with adolescence, but the age can vary. In early can be like diagnosed from infant, but up to like 32 years old. But mainly they start with adolescent. And this is a progressive disorder, very unfortunately. Some patients were initially controlled with anti-seizure medication, but then they will re-emerge and become medically intractable. So in these cases, the condition will be really tricky. And with a longitudinal following up of the neuroimaging, we'll find that there is a progressive neurocortical atrophy in patients with drug-resistant temporal lobe epilepsy. And for these patients, the timely surgical evaluation actually very important to help with them. And yeah, so basically, if we want to manage the seizure or the temporal lobe seizure, we should not treat the seizure itself only, because a lot of patients will also have many comorbidities about their cognitive impairment and about all kinds of psychiatric illness. So we should take care of all of these things when treating these patients and always give them a good plan. So this is basically all that I have for today's presentation. And these are my reference. And thank you for listening.